Well, good morning, everyone, and thank you all for joining us today. We are excited to have some of our experts from Emory's Education Office with us today. So we're going to have Dr. Erica Brownfield, the Associate Dean for Medical Education, Maria Aaron, the Associate Dean for Graduate Medical Education. Then we also have Dr. Philip Shane, Assistant Dean for Graduate Medical Education, and Dr. Jaffer Khan, Assistant Dean for Education, with us today. So they are going to go through, kind of share some stories about how the crisis has affected trainees here at Emory, the response to those challenges, and then provide some insights into the near and distant future of medical education and how things might be a little bit different going forward. Before I turn it over to our panel, I just want to ask that everyone make sure that your mic is muted. We will open the floor for questions and discussion toward the end. And then you're also welcome to use the chat function during that time if you have any questions. So with that, and without any further ado, I will turn it over to our speakers. So thank you.
Good morning. I'll thank you for your interest in what we do. And I'll start by throwing it over to Erica. But let me just, I don't know everybody's background. Let me just sort of explain who we are. Erica, is the Associate Dean for Medical Education, is responsible for what happens before graduation from medical school. So the training of our medical students, which is partly classroom and partly clinical. And then once they graduate medical school, my colleagues, Maria and Jaffer and I, are responsible for organizing the residency or graduate medical education, which is primarily clinical education in the hospital for young doctors who are specializing in their various fields. And so I think our challenges for the same issue are very different. Whereas Erica's people have been pulled out of classroom and out of clinical service, ours have been thrown in. And while we're suffering from an excess of education, and they're suffering from more of a deficit. Is that fair, Erica?
Yeah, so I like how you guys are ganging up on me 3-on-1, by the way. But to that end, I'll give you a brief bit of background and then the problems we face, and then I guess we can hear about your problems and your background, and then the challenges and kind of what we're doing near term and long term. So like Philip said, just to give you all some perspective, in 4 years of the medical school, we have about 575 students, and those are our MD students, our joint degree, our dual degree students. The 4th year students, when this all happened, and I say this happened, it was happening, but kind of like when it got really critical was around mid-March. And we had 4th year students who were 2 months shy of graduating, who had to complete clinical requirements for graduation. We had 3rd year students trying to get their electives in the specialty where they wanted to be. And we had 2nd year students who were literally 1 week into their year-long required clerkship year that got pulled. And our 1st year students, while they were in class, they were also in the middle of dissection for anatomy lab. And all of a sudden on March 13th, Friday the 13th, they got pulled, like completely displaced. So you can imagine for the 2nd year students who were starting a 1-year-long clinical curriculum, we had absolutely no backup plan for them for an entire year plus. This is where they were supposed to be, in the clinical clerkships, in the hospitals, in the clinics, and they basically were told, you cannot show up. So that was kind of like, wow, all right, what are we going to do about this? Our 1st year students not being able to go into the anatomy lab and dissect, that was a real issue. Our 4th year students who were trying to get everything they needed to graduate, that became less of an issue, and we dealt with that. But the biggest problem as to why the students were told they could no longer show up was it was a concern for student safety, which is our ultimate priority, lack of PPE, really the lack of clinical cases to meet their clerkship requirements, because all of a sudden in the healthcare systems, all the elective procedures and outpatient procedures, all these things started to go way down, and now you're not seeing any elective procedures happening. So basically, we also didn't have any testing for our students. Like, we could not confirm that if students were in the clinical environment, that they would even be able to be tested if they started to get symptoms. So we pulled them out. So those were kind of our background and our problems. Had lots of challenges, which I can go into. I don't know if you want me to do that now, or if you want to talk about the background and problems you all faced, Philip, Jaffer, and Maria.
Sure. So, yeah, for us, it was, I think like the rest of the nation, we were sort of seeing this on the news, maybe starting to get a little bit real, and then boom, that middle of March, it just exploded in our hospital as a real issue. So we have, we're not atypical, but we're a very large example of what we do. We're among the 10th largest graduate medical education program in the country, and we have about 1,400 physicians over 200 programs that span 4 different academic medical centers that are familiar with each other but are autonomous. So Grady is different than Emory Healthcare, is different than Children's Hospital, which is different than the VA. And our residents circulate amongst these. So we have a pretty heterogeneous group. The mean age of a resident is probably about 30 years old. So young professionals, young families, pregnancies, diverse backgrounds, highly educated, highly traveled, social media savvy. I wrote down a few things. Obviously, different specialties attract different personalities. So I'm an emergency room doctor. We're very much different than a highly advanced specialty surgeon or a radiologist in terms of our eagerness to get involved in a crisis or get ourselves dirty. And so there's different levels of comfort with caring for critical ill patients or dealing with ambiguity. So we were dealing with a high degree of complexity. So that was sort of my mirror of your description of the issue. The problems we had obviously were a new unknown disease with unclear transmission and mortality data, ambiguous and rapidly evolving treatment recommendations. We had emails coming out from different hospitals with vastly different information, which is really scary when you're walking into a hospital and you're not sure which set of protocols you're facing. We had contradictory and differing protocols, lack of adequate testing, which was really terrifying. It's sort of like playing tennis in the dark with no idea, where the ball is. And so we don't even know if you're taking care of a COVID patient or not, because you're just having to guess. Lack of clear support structures. All of a sudden, daycare went away. People suddenly had to worry about sick family members at home who might be susceptible to them bringing home infection, which is not something that we sort of think about on a day-to-day basis. Social media and news frenzy. There's no way to escape when you come home from work, the concerns about COVID. We had real supply chain insecurity and unexpected high acuity. This is a really ferocious disease, and even those of us who've been working clinically for a long time, we were really surprised at how fast and how sick some of these patients get. And we've seen a lot of cardiac arrest in the ER, sort of a disproportionate number, and that was really unsettling at the beginning. And then what I call redeployment anxiety. We started planning about having to back up frontline physicians with physicians who haven't seen patients for a while or don't typically see sick patients in their practice. And that was highly anxiety provoking for a number of our residents. So I'll turn it back to Erica for solutions.
Well, so I'm going to go over our challenges and then we can talk about solutions. So our challenges in no particular order. And I think each challenge we met, there was a ripple effect as to new challenges that it created. So You know, the first challenge was, what do we do with our displaced students? That was the biggest challenge, those who were supposed to be in the clinical environment. How do we turn things, we didn't want their learning to stop, so how do we turn the clinical learning into virtual learning if possible? How do we turn all of our learning into virtual learning? Easier done for the first year students and the second and the third year students. But how do we make sure that faculty are ready to do this? Just to turn on the switch. How do we deal with anatomy? We have cadavers in our building. What do we do with those? How are we going to teach anatomy? And we'll talk about solutions in a minute. How do we deal with this overarching uncertainty as to when the students can come back in the clinical setting? Because that's really when the clock starts again. And how does that timing affect everything we do now in the interim, and then on the back end about trying to get our students to graduate on time. At the same time, it was a challenge because the university was making announcements about what was happening with all the undergraduate students. And as a graduate school, we're allowed to make our own decisions, but are there conflicting messages? And so we had to make sure that we were in agreement with what we wanted to communicate with the students, and we were not going to make a decision to send all of our students home for the whole semester and say everything was going to be done remotely. We decided to take the stance that we were going to make difficult decisions as information was given. As you can imagine, those of you who understand medical school, there are all these licensing exams that they have to do. And so the fact that the Prometric centers are closed, and it was holding up students being able to take step 1, step 2 CK, step 2 CS. So multiple moving targets. Think about those students who are graduating. How on earth do you replace these milestone events like match day, their senior banquet, graduation? It was a challenge in terms of having one single authoritative communication source, lots of uncertainty and anxiety amongst the students, many, many questions. I've never gotten as many emails in my life as the last 5 weeks. The other thing that was a challenge is students really, really, really wanted to contribute, but they were told, you can't come in. So how do you deal with that? They felt sidelined, not being a part of the healthcare team, but understanding of what was going on. Big challenge when you're trying to educate someone to be a doctor that they can't have any in-person contact with patients and even their small group advisors. We realized that, and we knew this, but it really kind of came out in all this when we were going through all of our scheduling scenarios of what we would do, that there are so many students on so many different unique paths of their education, like dual degree, joint degree, those who have to remediate or who are delayed or waiting to do step 1, step 2. Like, you can't just make a solution for all students in each year because every student had a different kind of path. The other thing that we didn't realize that kind of came up, and you started hearing from this for our students who are graduating, especially those going to the Northeast schools, is they were getting all of a sudden these emails with these asterisks that, oh, you must, apply for your license emergently. And they were thinking, are they going to ask us to come early and graduate early so we can start to do clinical service? So we had to navigate that. Do students stay in Atlanta? Do they go home to do the rest of their education for the next few months while everything is up in the air? And really keeping our students engaged and enthused was really, something we're trying to do every single day. And so I think the last thing I'll just say in terms of challenges is, all decisions have been very tough and it's hard to do. And you can get very fatigued just making decisions after decisions on a day-to-day basis.
Right, and so again, our problems were almost the mirror opposite. In the emergency medicine, we change rotations every month, or the residents do. For us, the ones that were on sort of sleepier, less clinical rotations were going nuts because they wanted to be in the fray, and we had to, talk them off the ledge and not let them abandon what they were doing to come and help out in the emergency room. And the people in the emergency room were scared. Our biggest 3 challenges, as the cliche goes, were communication, communication, communication. with 1,300 residents, and our office doesn't have a personal relationship with the residents. We deal with the program directors. We deal with email, and suddenly there was dozens of emails with important information every single day. And it was hard to break through, but really difficult not to be forwarding important information. So we really struggled with how we were going to adequately communicate with 1,400 residents, all of whom are doing different types of specialties and different work. Obviously, we were dealing with a high level of anxiety and fear, even amongst the people who are comfortable taking care of really sick people. It was the unknown. So there was a lot of anxiety bubbling up in different ways. There's varying eagerness to contribute, as I mentioned, and it was hard to predict who wanted to be involved and who not. And then blind spots. There were things that we didn't realize were going to be issues. Our counselor, Nadine Caslow, was doing some debriefing of residents, and somebody brought up wills and advanced directives and powers of attorney, which is not something that we typically discuss with our 30-year-old, young physicians. But they started instantly sharing information, and it was clear that there's a lot of interest among getting their affairs in order as they were heading into this, which makes sense in existential crisis that you want to do that. But it never occurred to us that getting their will done was something that our residents needed. And then we're trying to support program directors, and being a director of a program is highly personal. You recruit young talent and you really mentor them and you feel responsible for them. And so we had physician program directors who were very anxious about their particular charges, and whether we were going to adequately be able to care for them as physicians and trainees and students. So Erica, do you want to start talking about some immediate solutions?
Sure. So again, these are in no order. And for those of you who know me, I'm all over the place. So I'll just go through it. So I think the guiding, for us, it was always student safety first in terms of any solution. So getting them out of the, off the front lines was very important. Managing their expectations has been really important throughout this whole thing. As Philip said, frequent, clear communication. We decided we were going to, instead of having so many different sources of communication, we were going to have one single source of kind of authoritative information. And that comes from me and Dr. Ely. And we do it for all the classes. And we've had several class meetings where we record them. We put them in one central location where people can go back and look at them if they somehow missed it. We've involved many people, including students, in going through the issues, talking through the issues, thinking about solutions, getting multiple perspectives, because lots of people have great ideas. So not trying to do everything on your own. I felt it was really important. I have to tell you, I'm an education dean and not a student affairs dean. So I didn't typically get a lot of emails from individual students unless it had to do with the curriculum. I have gotten probably thousands of emails from students with their particular issue. And I don't know, it's just kind of interesting. I'm like, wait a minute, where did this come from? And you just want to take the time to respond because it's really a high anxiety time, and just kind of responding to them. They've been very appreciative of just your time to do that. I think so being available, being honest and realistic about what you're going through and communicating that and being transparent with the students. We've had to form our own kind of crisis team to really plan for the best case scenarios and the worst case scenarios. And I say being prepared has helped us kind of feel better about this, because if you don't have any plan, it creates more anxiety for the students and for us. And so being able to say, okay, well, we know if this is the worst case scenario and here's what we can do about it, it's been very helpful. We've used guiding principles to make all of our decisions, and it's kind of known through our curriculum committee what those guiding principles are. We were very upfront with our students in the town hall meetings and their class meetings about what those guiding principles have been. we had to create non-clinical opportunities for students that would give them credit towards graduation, but it would not replace their clinical experience because we can't do that from an accreditation standpoint. And I have to say that the departments have really stepped up out of nowhere. I don't know if it's just because they're not working as much, but we have had, like in the last week, 37 people create new electives, whether it's telehealth electives, whether it's literature and medicine, whether it's quality and safety, to, you know, let our students still continue their education in this time when they're really eager to do something. We repeat important points over and over in any communication. We have been providing resources to students, whether it's from the Office of Religion, whether it's the CBCT, whether it's yoga. We provide them resources, mental health resources, so they have those. We have a system where each student is paired with a small group advisor, a faculty advisor, and we've actually, from the university and provost office, but really on our own, we've also mandated that there are even more frequent check-ins with each student. We're documenting that we know that they're engaged, that we know they're doing okay, to make sure that we're not losing track of our students. I think here, the last few things I'll say in terms of some of our solutions is really looking at peer institutions and even nationally, because there's been a lot of collaborative effort, and because every medical school is facing the same thing. So what are people doing, and how are they navigating this? And that's been very helpful. A lot of flexibility and really bending the rules without compromising our education, you know, the education of the students has been really important for us. And the students themselves, you know, they banded together and they formed this phenomenal way to volunteer, have a beautiful website where they have just cataloged everything. So they've empowered themselves to feel like they can be engaged and help in this whole pandemic.
Yeah, so we've missed the students, and you know, they've always been helpful, but they're also really just part of our ecosystem in the ER. And you know, we task them with a teaching point at each shift, and they're part of our debriefing at the end of each shift. But you know, we're really worried about our supplies of protective equipment, and it was hard to justify right now using up extra equipment for educational purposes, or worrying about students, you know, not being sophisticated about all the precautions and getting themselves hurt or sick. You know, it was interesting. Maria is really good at communicating compassion and concern. It didn't really occur to us that when we're dealing with physicians that they needed to hear that. And one of the things that we stumbled on that really spoke well was just saying the simple stuff from our office, is that we will take care of you if you get sick. You have to stay healthy. You cannot see a patient if you don't have the proper equipment. Just some real simple things, which for us seemed obvious because we were spending so much time trying to ensure that they had those resources, but we didn't think to just say it. But Maria put out an email that just laid out some of these basic principles, and it actually was put on Reddit and went national under the title, here's an institution that actually cares about its residents. And there was a lot of concern nationally that residents weren't going to be cared for, and it was really important just to state the really obvious, simple principles to our residents. We hit upon email discipline, and instead of forwarding, you know, important faxes that came up, we've been sort of Maria's been collecting them, and she's become an editor and putting out roughly every other day a digest of all the important points, and not just the new things, but repeating the things that we've already said, because there's so much going fly. It's just so that it becomes obvious. Oh yeah, I remember that's always in the email. You know, which phone numbers you call if you get sick, what to do about equipment, what the story is about being redeployed to another service. So we were disciplined, and we've been repeating the key points regularly on these emails. I don't know if Marie wants to talk about it, but we had the opportunity to relax our training standards, meaning that we jumped through a lot of hoops to train and graduate our residents. Some of them are more administrative than others. And the ACGME that accredits residencies has allowed us to go on stage 3 pandemic alert status or whatever they made up, which lets us do some things like be more flexible about canceling conference time or didactic time, which for instance, in the emergency department has let us rest our residents a bit more, give them a little more time off so that they're fresh, because we're worried about them burning out. And so we've gone to a system of having some residents off at every time so they're ready to relieve the ones that are working. And so having that national flexibility has given us some good tools to use. Let me just see what else I had on my notes here. Website, we put the medical students have an excellent website of resources for healthcare workers. We've put together a website just of all our emails and the frequently asked questions and with various links, so that we can keep referring the residents to that for this sort of information. Something that maybe sounds obvious but wasn't obvious to us is that you can use Zoom for listening, not just for presenting. And so having these town hall meetings where we say, for us, our constituency are program directors, hey, what are your anxieties? And then letting people chime in was not something that we had done before, but I think has been incredibly effective, as opposed to just a method of spewing out information, using Zoom to listen to where the problems were. Mental health services teleported really quickly, or ported really quickly to telehealth, and stood up. And we've always been concerned about connecting residents to mental health needs. A lot of times there's unexpected death or some difficult situation that a resident needs to debrief or work through. And it's always been hard when they work long hours to get them in a timely manner to mental health services. And going to Zoom actually and standing up the clinics by psychiatry has been super helpful, and I think a model that will survive once we're over this crisis, because that seems to be working really well. And it doesn't seem like the human touch is as necessary as availability. There have been a lot of wellness resources, and a lot of people have stood up their apps now that are free for healthcare workers, on mindfulness and yoga and all the things as a boomer that I'm not good at, but the residents seem to really like. We're still working on access to testing and treatment. It was very hard to get tested if you got sick, and we've been very persistent about pushing the fact that they need to test our residents so that they can know if they've had it or not. And because it's really, when you get these symptoms and you've been around a lot of sick people, it's very anxiety provoking. And so finally, we've stood up legal services. The law school is opening up a clinic for residents to get help with wills and advance directives. The business school has offered financial counseling. We finally have housing available now for people who get sick, so they don't have to go home to their families. And we're working on some hardship funds for residents who have particular issues.
Great. So I'll just talk about real briefly the near-term and kind of long-term issues that we're looking at. And I'll just say a couple words about some positive things that actually have happened. So near-term issues, we have students who are graduating on May 8th, and there are some things that historically we've provided for them before they start their residency, whether it's TB screening, ACLS, certification, that sort of thing. While we were successful in the TB screening, as you can imagine, after an exhaustive search, internally and externally, there are no ACLS certified instructors that we can find who will actually come teach our students. So this is something that unfortunately UME is handing off to GME, as GME knows that's going to be a huge challenge this summer when they're going to have to train all of their incoming residents. Our biggest thing right now is, when can our students get back into the clinical environment? What are our guiding principles? How do we talk to the Emory Healthcare, Grady, VA, CHOA? How do we come to an agreement about the phasing in of our students back into the clinical environment? When can we start using simulation right here in the School of Medicine? Because there are things we can do to social distance and ensure safety. When will the USMLE Prometric testing centers reopen? It's a moving target. Every 2 weeks we get a new date. We don't know, and that's putting a lot of things on hold. How will students get exposure to their specialty of choice and get letters for the residency program they want to go in? This is a national conversation. Everybody's kind of waiting for the medical schools across the country to come up with a consensus, because if some students are allowed to go some places and do kind of these audition away electives and other students aren't, there may be students who feel like they're a disadvantage when they apply for orthopedics or neurosurgery or something like that. How is ERIS and the interviews going to work? They're talking about changing the deadlines, which a lot of things on a positive note we've been wanting from a UME standpoint may actually happen with this pandemic. Because of the pandemic, the question is, will it go back to what it was before or not? Can we graduate our students in the class of 21 and 22 on time? We're hoping that we can. And then what happens in July when the new incoming medical students are supposed to be here in person? Will they actually be here in person, or will it be virtual? What do we do? The longer term issues, what if we can't get students back in June or July? What drastic changes need to be done with our curriculum? How do we look at that when we're going to have already overlapping, so 2 classes at a time for several months in our clinical environment, where right now it's already a challenge to get our students placed in the outpatient setting. Now if we're doubling the numbers and outpatient practices are struggling, to keep their practice, and what are they going to do in the future? How is that going to look for us? How do we, if we make changes now, because we are making a lot of changes, does that set a precedent for the years to come? So if students hear, well, hey, they were allowed to do this, why can't we do this? That sort of thing. And then the other big kind of thing on the back of our mind is, what if this happens all over again in November, December, January? I mean, if this is a seasonal viral illness, what are we doing now to make sure we have a backup plan for our students so they can continue? And that's a big discussion with our healthcare partners. How are we going to, what are we going to do? On a positive note, and then I'll turn it over and I'm done, this has truly been a very collaborative environment to work in. And like you said, Philip, our School of Business, School of Law, we've run an elective on COVID-19 over this last month, and it's unbelievable who has agreed to be part of this elective. And it's not only inside the institution, it's outside the institution. There's really been no blame, no one arguing, complaining. And students like to complain, which for good reason, right? But now they're not really complaining. They're just more trying to figure out how we're dealing with things, but they're coming about it in the right way, which is great. Despite their anxiety and their uncertainty, they're very supportive of what we're doing and how we're handling it. That's great. This has really opened up a spark of creativity amongst our faculty and our students and administration to say, what are we doing with this? How can we relook at this? How can we learn from our colleagues? And it really is an opportunity to change things we've always wanted to change, right? So we knew we wanted to change something. Well, now's the opportunity. Let's do it. Let's pilot it. Let's see what happens. And it's really nice to be part of an environment where you see people, maybe even some of the quieter people, step up to really lead. Everybody come together and feel united, even though we're not in the same room with each other. So those have been some real positive things.
Right. So we're facing sort of the same timeline and deadline as Erica. We're looking to graduate residents, and some of them are looking at having, we haven't had the normal evaluations recently, we haven't had the normal cases that they required. And so trying to figure out is if they're prepared with all this confusion and chaos at the end to go out and practice independently in the specialty that they were on track for. That's going to be difficult for program directors to adequately assess, and obviously crucially important. July 1st is always a bit overwhelming for us because we turn over about a quarter of our workforce, and we have new residents coming in that have never had a paycheck before for some of them. So they're coming on as employees, they're coming on as physicians, they have to get licenses, and the amount of work that we have to do, we don't even know how many are going to be able to show up now July 1st. Whether we can have them in a classroom, there's some things we can do virtually, but it's hard to give somebody a pager or test or teach them how to wear a mask online, and we're just trying to figure out how to do that. What can we do with simulation? Simulation is a great auxiliary method in medicine, but it's very faculty intensive. And so, can we set that up in a way to help smooth some of this transition? And we just really don't know when services are going to be normalized. How do we take in a fellow who's going to be doing some highly complicated procedures if we're not doing those procedures for the near future? But I will say that the community support has been unbelievable. And in my 30 years, I've never felt more appreciated. And I've never heard more people say yes. Even the people who don't like to say yes are saying yes. And we've had all these people just, contact us and volunteer to help. And it's really been uplifting. And we've really been proud to feel like we're part of the solution to this. And I think we feel pretty optimistic that we got this under control. I don't know if Maria or Jaffer have anything that they want to add to that.
Outstanding, Philip. I think you highlighted so many good things. The couple of comments I was going to make is that what we found is that relationships have been really, really important, and not only the relationships that at leadership level, but also that the relationships we have with our program directors and with some of our residents. And I have to say that our house staff organization has been really partners with us. And we could not have done this without that partnership, because we need them to be on the same team that we're on. And so they come to us immediately when they have concerns. They call us on our cell phones. And those relationships have been so important. In fact, we were worried about over communicating, and they gave us feedback that we were under communicating. And so, it was so valuable. So we ramped up the communication so much more, and we felt like we were bombarding them, but that's what they wanted. They wanted a lot of communication. And really, just so importantly, the compassion, I think, is really, really important. These individuals are young adults, but they're afraid of going into these environments. And so it's been important for us to sort of reassure them that we are there. Their safety is our top priority, that we are going to support them. And so we've been careful about making sure we communicate that. And nationally, it's been really interesting because we've had institutions that are at all stages. So there's ACGME has been great partners. They have allowed us you can be in stage 1, 2, or 3, and about 20% of the programs are stage 1, about 50% are stage 2, 55%, and then about 20 or 25% are stage 3. And while it's been great to have some communication, lots of people are at different levels. And so finding institutions that are sort of at your same level has been really helpful. But the ACGME, the national organizations, I have to say, have been really on top of this and really helpful in relaxing a lot of our requirements, because we just can't take care of these patients if you've got all of the program requirements that we normally do. And like Philip said, and Erica, there's been a lot of positive that have come out of this too. People, the community, the relationships, the telehealth. I know Jaffar's talked about this yesterday, but it's really helped us to move forward in many ways that I don't think we otherwise would have done. So there are some positives at the end.
So I might, yeah, thank you. So I agree with everything that was said, and Philip, Erica, you encapsulated everything that we've been going through beautifully. One thing that I've learned throughout all this is a lot of the anxiety and the frustration that we see among residents, trainees, students, faculty, program directors really has been transparency. Whether real or perceived, it doesn't really matter, because perception's reality when you're feeling like you're not involved in decision making, or you're not involved in what's going on. No one's telling you what we should be doing. One of the worst things for our very, very motivated students, etc., really is to feel like you know what the right answer is, but you cannot do anything about it. And so I think that communication really has been important, because if we can just let it flow, then they get an understanding in a timely way of what's going on, and can also see that changes are being made in response to what their concerns are.
So we'd love to take questions. And Maria, I love how your teenager and your dog were in the background.
It's so hard. There's 3 kids, 2 cats, 1 dog.
I can understand.
Mine won't be up for a couple hours.
Yeah. So Katie, do you want to field some questions, or we can certainly field them?
Yeah, we can definitely do that. So folks, you're welcome to use the chat function if you want to ask a question in person, or virtually, I should say. You can just unmute your mic, and then ask your question that way.
Hey, Holly. We can't hear you.
Is that better?
Yes.
Yeah. Okay. You'd think I had to get the hang of unmuting after all these Zooms. I was trying to get to a quieter place to ask my question. So it's really for both Eric and Philip. I'm Holly Gooding. I'm relatively new to Emory, and one of the things that I have been wondering about that relates to the graduation and the starting, more for the students in the graduating class of 2021, is whether people are talking about the return to the transitional year. Erica asked this question in another forum that we were at. Nationally, it just seems to me that it might be one way to address the need for students to enter the workforce when they're still sorting out their career intentions. So deciding I'm going to be a surgery intern, a medicine intern, a pediatrics intern, but really in a more open way, like the transitional years of yore. And I'm curious whether that's something that people have been hearing discussed. It's something I've heard a little bit in some of the national medical circles that I participate in.
Yeah, and Holly, I'll be honest with you, I haven't heard too much talk about that yet. I mean, maybe we have a unrealistic optimism that we're going to be back in the next few months. And so if that becomes less optimistic, maybe we'll start hearing more of this. But I personally have not heard a lot about that. It will be, the more things I've heard about what students are most concerned about, and on the national level, is think about those medical schools that don't have the subspecialties that students want to go into. And if they're trying to do an elective in orthopedic surgery, but they don't have a residency program in orthopedic surgery, are they going to be allowed to go to somewhere like Emory to do that audition rotation? or not, when Emory's dealing with all of our own medical students and overlap with it. So it's going to be really interesting on the national level. Is there some kind of understanding or agreement amongst medical schools? You want to even the playing field, but how can you do that and also meet the needs of your own learners at the same time? I don't know the answer to that.
I haven't heard the discussion relates to this crisis. It's funny that Maria is an ophthalmologist and Jaffer is a neurologist, and in emergency medicine, we all did preliminary or transitional years, and that was a really key point of my education. But it's become a bit of an anachronism, and medicine's pushing you towards specializing early and losing that broad foundation. It's funny though that we're asking a lot of our specialists now to come back and be on the front lines. And they're really digging back to those early years of their training. I think we're seeing the value of having that broad education.
On a different but kind of interesting note, there was, I think it was in JAMA or somewhere, I think you probably saw this, Holly, there was this kind of article out there: should all incoming medical students starting in 2020 not start medical school, but actually take a year and do service, and then come back when things have kind of settled down and start medical education then? It's an interesting discussion.
Yeah, I was on a webinar with some people from Penn State University, which has had a real push towards giving students early authentic roles in the first year that are really meeting the needs of health centers, so serving as like medical assistants and things like that, writing with EMTs, these sorts of activities. And they were talking about how, because they had that structure in place, they've been able to do that somewhat locally, to like have students already embedded as essentially like public health workers. And so it was a really interesting concept, like really working. They already felt like they had the relationships with the leaders of their academic medical centers who are accustomed to putting students in these really working roles from a very early standpoint, so that they were able to scale up and deploy in that way. It was really interesting.
Right, and it's great. Part of the issue when students volunteer, we can't tell them how they can volunteer their time or what they can do. We have no oversight of that. But it's always been our priority: safety first, safety first, safety first. And, students are asking every week, well, can we potentially go back and be part of the screening? And it's like, well, if there's no PPE and that they're telling you there's no PPE and you can't be tested, you really need to think about that, because we're definitely, for any requirement on our end, that is a necessity. Both of those two things it's a conversation that has to happen with those two things being first, is, making sure to protect our students. So hopefully places like Penn State, if the students are already so integrally involved in providing certain services, they've kind of, already been advocating for that for each student. Right now, we just need to continue to work with our healthcare partners to say, when will we be able to bring them back? When do you feel like the surge is over, and will you have enough safety, mechanisms in place for our learners?
And we battle this reputation or sense that we exploit young physicians, and we work very hard. And so then bringing in medical students and using them for service things fights that, goes against the stream of what we're trying to say. So we want to be very careful to use residents and medical students for educational purposes and really value, and not use them for the gain of the system.
Other questions?
So while they're thinking, I will say this: another thing to keep in mind is when we make any adjustments now, whether it's delaying graduation or whether it's sending students off for their first year of medical school to do service and come back later, it's going to impact the influx of trainees who graduate from UME from medical school and then go into an internship, right? So there'll be less of a pool potentially. So we really have to be careful with decisions that we make now and the ramifications that we're going to see in 1 year and 2 years.
Well, we appreciate your interest in what we do.
Perfect. Yeah, if there's no one else that wants to kind of share their stories of maybe how they're interacting with students or trainees in the time, or any other questions. Well, hearing none, I think we will kind of end today's panel, but thank you all so much for that information. It was really great to hear. I love hearing about all the stories of creativity that are coming out of this and the collaboration that's being experienced. So thank you all for your participation today, and take care.
Thank you,
Thank you.
Katie. Bye.
Bye.